Good afternoon, everyone. I am really happy that we were given the opportunity from Stroke Action Plan together with Philips to organize this advocacy masterclass. And you are all very dedicated to advocacy probably because you applied for this. And I see some familiar faces. So we tried to build the program from the beginning. So you can be just a young physician interested in advocacy, or you can, of course, be old dog and master politician who is already doing advocacy in their home countries. So that's why we have, program from A to Z. Sorry, I need to go for the program slide, and I am not sure.
Black laptop.
Right laptop or left laptop?
The
Left
the
laptop.
left, yeah.
Okay, a little bit confusing. Okay, so basically in the beginning we are just now waiting for Hanne Christensen and she will give us the background why stroke is the problem. Then we are very happy to hear from two very experienced ladies, Ruth van Asperen and Angelique Belkit, and they are experienced doing campaigns and advocacy in other areas, not just stroke. And then we have, in this part, there will be some interactive part, which will be headed by Francesca and me. We will be moderating the questions for you, and we will have some outputs out of this. So if you are not yet, some of you registered, but if you just was walking by and came in, just provide us with email, then you can be, we can send the materials after the course. So I think, Francesca, do you have some news about Hanne?
No. Michelle is looking.
Are actively looking. So basically.
Basically, you start. You're standing there already, so you know.
So we can go for the first question from where they are and show the mechanism. Angelique.
Yeah, sure.
Or Ruth. Yes. So I think
we can test already.
we can just explain the interactive part and you can try to download it. So go for it.
Okay, so we will use Mentimeter for the questions, and we can already maybe test if it works on everyone's phone. So you can take your phone and then we will show you a QR code. And I will just scroll to the slides. This is the QR code, so you can scan it or you can go to the website Mentimeter and then use the code which is on the screen. And then we have a first test question for you, which is, which country are you from? So let's check if it works for everyone. It's the same Mentimeter the whole time, so you can just leave this open on your phone. And also for the other questions that will follow, you can just use this link. Works for everyone? Any issues? Okay.
Okay, so we will see the results now.
Yeah. Can you see it on the screen?
Okay.
It's working.
And you see it's working.
Okay, first test. Check.
Okay, it's changing. Oh, I need to put my hand.
Yeah, and we can like on the bottom we can see how many people are actually already in and how many people voted. And you can indeed do your thumbs up. You get an error? Or
Is it working?
And we have pretty wide ratio.
yeah, so the bigger the word is, the more people have filled in actually that word.
Okay.
Okay, good to know that it works and that everyone has access. And we will use this during the presentation. If we are still waiting for Hanne, should I otherwise just start?
Yeah.
Yes.
What is the...
Well, let's go together.
Okay, so if Hanne comes in, then we will move to her part first. but-
Alice is going to do it on the presentation.
Oh, okay, sure.
Yeah.
Okay.
Yes.
So you can just choose.
Yeah.
Yep.
Of course, it's a teamwork, so we can step up. So, as you know, in the past, when you looked at the cardiovascular health programs, it was usually all about myocardial infarction. And us as neurologists were not happy. Of course, it had its reasons. Cardiologists were doing treatments 10 to 20 years ahead of us. So they had something to offer to politicians, to healthcare systems. So if there is some solution, you can try to sell it to the system. So that's why they were ahead. But now we have also a lot to offer. We have proven what are the correct treatments. We have effective treatments, thrombolysis, thrombectomy, stroke unit care, everything. So basically what we are now trying to do, and what the governmental agendas are starting to reflect, as you can see here in United Nations Sustainable Development Goal and in the EU Health Year Together.
Different computer.
Oh!
Different computer. We're seeing only the first slide, sorry.
Okay.
Yeah.
Sorry guys, this is confusing. Okay, but now I'm in. So those bigger organizations already understood that stroke is an agenda. But it's still not reflected in day-to-day practice, and maybe it's by nature of neurologists, of us, that we are more polite people, not so aggressive sharks like cardiologists, that we are not pushing the agenda so much. But we need to be sharks, at least for this. So our governments, they know it, but we need to come forward and tell our governments to do something about it. I know it's happening. We know it from Stroke Action Plan that it's happening, but we need more, basically. So now we know what should be the targets. I see here at least 20% of you are national coordinators of Stroke Action Plan Europe. For those who are not knowledgeable about this, this is the biggest program, or policy program. Francesca is chairman just from today, and she will be talking about this also later. So this is the program that defines what should be done, what are key performance indicators for every country, what are the targets to these KPIs, and that every country should comply with those targets and indicators. So there is now time that we have the methodology. If you are not knowledgeable, please go to our webpage. You can find it under ESO, or just put in Google Stroke Action Plan Europe. So we know what is the situation, and we see great inequalities in the care. So I know that some of you saw it, but just look at the colors, like in general, like artistically. You see it's mixed colors, red is bad, green is good. So you see the inequalities in Europe. And what is interesting, you will always find a red map for country. Every country, there is like not one country that is 100% good in everything. So even if you are from a well-performing system, there is still something that you can do advocacy for. Of course, the advocacy part will be different. If you are living in Tajikistan, of course, your goals for advocacy will be much different. If you are living in Netherlands, of course, your goals will be different. Hanne? Hanne, I think we can switch now.
Well, let's switch. I'm really, really sorry. I got completely lost. I came from the ESOC television and I got lost. So sorry.
So I think I can introduce Professor Hanne Christensen. And, and Hanne will show you, put it this. Yes, this laptop, not this laptop. And...
But you see,
and
there is
Hanne,
a lot of people coming now, so it means that, that there were...
Yeah,
we
so
were
I
very
just
tight
said
with
that
time,
we have
so it's
inequalities,
okay.
and the Stroke Action Plan, thanks to you and to Stroke Service Tracker data, has a possibility how to identify targets for the advocacy. Now it's yours.
Exactly as Alice said, we can use the Stroke Service Tracker data to identify the gaps, and we need to identify the gaps in our individual countries. I think this will be the talk of my life. We need to identify them in our individual countries, and we need data to identify them, because a hunch will not tell you where the needs are unmet. And what is really important is, if we look at it, there's also a strong geographical relation between the European regions and how good the care KPIs are met. So this is what you see in this figure I entered. So how do we get there? We get there by, and this is the words of Peter Kelly that I'm quoting, the golden triangle of improving stroke care. And what this is really about? That is about getting the collaboration between the governments, the ministries of health, because those are the ones who can make this kind of decisions and who can fund them. But to get there, we need the collaborative efforts from the stroke support organizations and from the stroke scientific societies. Patients can demand change. Patients can demand better treatment, whereas we as physicians, we can only recommend and we give scientifically based information. If you look at what should then the first step be, the first step should be a national stroke plan, because the national stroke plan, that is to have an overall setup covering how to treat stroke and to have it funded and to have it implemented. If it's just a sheet of paper in a drawer, it won't help or hurt anybody. You need to have it implemented. On the right, you can see these figures, and the one on top shows that countries with an implemented national stroke plan, they meet significantly far more key performance indicators, and therefore we must perceive they have far better care than those who have ongoing work in making a national stroke plan, as well as those who don't have one. And a very important part of a national stroke plan, which actually improves the quality, that is having a quality auditing program. So why stroke? Why now? Now I'm responding to the questions from Alice. Yes, the strong collaboration in the SABI. That is because we have a very high burden of stroke. If we look at incidences, we will know that the incidence of stroke is happily going significantly down in almost all areas. Some are still in Europe at a very high level, some are lower. But due to the aging populations, the actual number of strokes that come into our hospital is increasing. It's the same thing as it would look from the incidences that the vast majority of our patients would be men, but this is not true. That's because women live even longer and therefore have time to have strokes. And why now? Because there is a significant need. With this aging populations, with the increasing number of people coming in with strokes, and the very, very large burden not only on patients and carers, but also on the society through the economic impact, we need to do something about NCD. We need to do something about stroke now to stop this kind of invisible tide. And what is really important is that we actually have evidence-based and cost-effective means. So we do have the kind of cure. I'm not saying we could rule out stroke, but we certainly have something which could turn the tide. And there is right now a window of opportunity. So, thank you. This was the talk. And now I will ask you the first of these meter questions. You have already been introduced.
So we can do it again.
We could do it again. Yeah, we have more people.
More people. More people.
coming.
Let's go it.
No worries. So,
Scan the code.
yeah, so for the people that
Again.
joined a bit later, we already started with a test question in the beginning. We will use Mentimeter to answer some questions during the session. So for the people that joined the meeting a bit later, you can either scan the QR code or you can join on menti.com and use the code which is on the screen. We will also bring this up another time later in the presentation, but let us know if you face any difficulties. We already did this first question, so I will not show the results now, but we can go back to it.
I think there, because we have more people that have.
We wanna go back?
Yeah, let's do it again, or let's.
Yeah.
Yes.
Let's do it
At
again.
least
or continue.
25 people
So
came.
this is okay. That's true. Okay, this is what we already had. So for the people that already filled it in, thank you so much. We can actually see that 72 people are now in the Menti room, and you can just fill in one word,
Netherlands.
so we better understand who's in the room. Thanks for the thumbs
Italy.
up.
Italy, yeah.
Armenia. Big.
Armenia is the biggest.
Yeah,
Yes.
quite a lot of different nationalities, so that's good to see. I hope it works for everyone and that everyone is able to enter
Denmark.
the
Big.
Menti room. Then we go back to the slides. All good for everyone?
Yeah.
Okay, perfect. So we will use the Mentimeter later on as well, but we will first start with the workshop with a few slides. So maybe to introduce myself, my name is Ruth van Asperen. I work for Philips in Amsterdam now for almost 5 years, specifically in government affairs. So I'm not a stroke expert, so I'm a bit different in this room, I guess. I have a background in cardiovascular research, but I'm now focused fully on government affairs within the company, which means that it's all about health policy, advocacy, and global partnerships. And I will explain you today a bit more what the theory is behind advocacy. So what is advocacy? What are some best practice examples? What is a framework you can use for it? And how could it work for stroke care as well? So I have a few slides on that. The first slide kind of shows you the definition of advocacy, because it's a word that is often used, but a lot of people don't really fully understand what it actually means. If you look at the slide, advocacy is the process of actively supporting, promoting, and arguing in favor of a cause, policy, or group of people. And it involves strategic actions aimed at influencing decision makers, public opinion, and systems to create positive change. Quite a long definition, but in the end, everyone can be an advocate. So what you often see is that health professionals are advocates, but they also group together within, for example, organizations, or patients group together in patient organizations. You also see that there are different civil society organizations that come together to advocate for a certain cause to actually create positive change. And that's also how I kind of ended up in this field. I was more in healthcare, but I really thought, okay, how can I make a big impact? Well, by doing advocacy, you can really make a big impact. And why is it actually impactful? There are a few reasons for that. The first reason is that it influences policy, so it actually shapes laws and regulations. It amplifies voices, so that means that also people that are often unheard, so that are, for example, unrepresented groups or marginalized populations that are normally not heard in decision making, they can actually make their voices heard by doing advocacy and by teaming up together around a certain cause. It also builds awareness, so it also educates both the public, but as well as key stakeholders about a certain critical issue. It drives change, so it can really make change if done in a sustainable and a sustained way. And it also can mobilize resources, so it can also draw attention to certain critical causes, and therefore also improves the funding into underfunded critical issues. So that's a bit the background of advocacy. Then if you look at two best practice examples, there's a lot of text here, but it kind of shows what two best healthcare advocacy examples are from the recent years. I think a lot of you know the first one, which is all about COVID. So what was achieved by the COVID-19 Vaccine Equity Alliance and COVAX is that it raised global attention on vaccine access disparities between high-income and low-income countries, and it had a huge impact, and also a huge impact by actually pushing a lot of pressure on governments and pharmaceutical companies. The tools that have been used to advocate for this and to bring this to the public are public campaigns, international media, but also engagements with the WHO, so the World Health Organization, and the United Nations. And that was already mentioned in the beginning. There's of course a big healthcare agenda by the World Health Organization and the United Nations. And we as stroke community can also be smart to kind of tap into that global agenda. So what is on the agenda of the World Health Organization and the United Nations, and how can we advocate for stroke as part of that? But this specific example was also led by a coalition that also included the World Health Organization and a few other civil society groups that together teamed up and made a lot of noise about the need for vaccine equity. We as Philips have not been really involved in this first one because it's about vaccinations. We are not in there, but the second one is a program we have been involved in, which was all about advocating for health system renewal in Spain, which all had to do with the fact that a lot of the medical equipment in Spain was outdated. It had to be renewed. So also here a group came together, which was actually led by the government of Spain, together with local healthcare authorities, but also with the medtech sector and trade associations, to advocate for change and make sure that healthcare could be done in a better way by improving the health system and the equipment. And why are these two examples impactful? So why have these two things been a success? Well, this is a theory. It's called the window of opportunity. It's not a theory I came up with myself. It's from a political scientist. John Kingdom is his name. And what he said is that 3 streams need to be aligned to actually be successful with your advocacy strategy. And the first stream is about the problem, the second about policy, and the third about politics. So if you look at the first one, the problem stream, to really be successful and lead to policy change, the issue or the problem needs to be recognized as urgent, and it also needs to be seen as something that needs action. So it's really important that you define a clear problem or a clear issue, which is also recognizable and which resonates with your audience. That's kind of the start. Then there needs to be solutions for this problem. So there needs to be certain evidence-based solutions that can actually help to overcome this problem. And then the third stream is that there also needs to be political will or momentum for action. So that could be either that there are elections which give new momentum. It could be that there is already certain people in leadership that have a certain view about the topic, and therefore this is a good momentum. It could also be that the public is talking about the topic a lot, and therefore it needs to be addressed. So there needs to be both a problem, clearly defined, a policy with solutions, and a political will or momentum for action. And if you reflect a bit on stroke and how stroke care fits into this window of opportunity, you could say the problem is well recognized by everyone, at least here in the room. It's a leading cause of death and disability globally, and it has a huge impact on society. The incidence of stroke is rising. There is a big gap in access to care, to stroke care. So there is a clear problem definition. Then if you look at the solution, so the second one, there are also clear solutions for stroke care. So we know prevention, stroke units, cost-effective treatments, rehabilitation. So there are clear solutions to address this problem. And then if we look at the third, so the politics, there is also huge momentum currently. So that was the first slide that was already presented. But within the United Nations, there is every year a high-level meeting on a certain healthcare topic. And this year the topic is non-communicable diseases, so NCDs, which also includes stroke. Last year it was, for example, or 2 years ago it was tuberculosis, maybe next year it could be HIV, but every year on the global health agenda there is one key topic that gets attention, and this year it is NCDs. So that also gives us kind of a window for of opportunity to make sure that stroke care is actually part of this NCD high-level meeting, and that stroke is discussed and seen. And also all countries that are involved in this global health agenda, they will also all sign so-called political declarations. So those are all documents that kind of give guidance on how to deal with NCDs, and therefore stroke should be part of that. Also on a regional level, as already showed in the first slide, there are many EU initiatives also around NCDs. So there's really a momentum now to talk about stroke care as part of the global health agenda, and also on a regional level. So we know that the time to act is now, but how do we actually advocate for stroke care, and how do we come up with a clear strategy to advocate for stroke? This is a 6-step process that is often used in advocacy, which kind of shows the different steps you should follow to build an impactful advocacy strategy. And this is something we would like to do with you today, to kind of see, okay, what are the steps we should take, and how do we get to a clear story and strategy for stroke. So the first step is set your priorities. The second one is the analysis of the situation. The third one is to define your objectives. Fourth step is to understand your stakeholders and build a story that resonates actually with your audience. The fifth one is to build alliances, because as you see in the other successful examples, you can often not do this alone, but you need to do this together with others. And the sixth step is to identify outreach tactics to actually reach your audience. Well, the stroke action plan for Europe actually already kind of covers the first 3 steps, because it talks about setting priorities, about the situation analysis, and it also defines a clear objective. So this is one slide that Hanne showed. So the first step is to set your priorities, and it's about deciding where you are going to focus your efforts based upon the political landscape and the trends. So it's really important to look, okay, where is my country and what should I focus on? So this slide shows that there is, for example, maybe there are limited stroke units. Maybe there needs to be more focus on secondary prevention. There are many things you could focus on within stroke care, of course, within your country. But it's really important as a first step to set your priorities. So what is that? What is it in your country that you're going to focus on that you would like to change with your advocacy strategy? And therefore we have actually a question. So you can take your phone again for the Mentimeter. And the question is, which topic in stroke care should be prioritized through advocacy to improve outcomes in your country? And you can choose multiple topics on the list. It's not that one is more important than the other in that sense, but it's kind of to see what do you think you should focus on if you think about advocacy and raising awareness? And then I'll...
It's working.
Yes. It doesn't work yet?
We have again the countries.
And now we are there.
Yeah? Is it now showing up in your
Which
phone?
topic in stroke care? Of course, they are all important. But what we know, what we learned, what we heard just now, that what is important is to discover what are the unmet needs that we can do something about. So where we can intervene.
We can see that almost 30 people almost 40 have voted.
Yeah, carry on voting. We're very interested in your...
Very nice.
Okay, so okay, interesting. So just go.
It's moving.
We are in 2/3, so move it, people. Decide. We are stroke physicians mainly, so you need just 5 seconds for decision.
Yes. Time is brain.
Okay.
Comment maybe.
Yeah, that's... I think it's very interesting because what we can see is that increasing public awareness and early recognition of stroke symptoms, so activating the chain of life, so activating the acute phase and all the interventions related to the acute phase is one of the poles. And then we have strengthening post-stroke rehabilitation. They are all important, as I was saying, but it's important also for us to know what we can pragmatically do things about, so where we can intervene. And we have also life after stroke, of course, comes after the other 2 points.
Yeah, I think it's interesting. We would like to see, of course, as we said, each one of you, every country needs to decide by themselves. Of course, if you don't have, let's say, at least, basically functioning stroke unit network, then of course that's your key goal. And then after that you can concentrate on public awareness and so on and so on. But you see many good answers, not the best for everyone. And I think we will get to it that you need to carefully select. We are not going to tell you what your country is going to be doing, or not here. Maybe SAPI will advise you in the future. But interesting. Let's go further.
Yes, this is, this is what it's relevant for each country, is to have a situation analysis. It tells you what are the priorities, where to work on, the unmet needs, and so especially where there are the quick buys. What are the actions that you can put in place to obtain something quickly and efficiently, and of course where you can act better. So where you have you just saw the pyramid where there is the political will to act on a given problem, whether it's rehabilitation, whether it's public awareness about stroke. It's very important that you're very well aware of the situation in your country, and SAPI is an extremely powerful tool from this point of view, because even it gives you the possibility to benchmark within your country and see where you have chances, opportunities, where are your strengths and where are your weaknesses. So this gives you the possibility to analyze that, and so to bring together the stakeholders and all the other relevant players in a given area and propose a program, possibly obtain a result to improve stroke care in your country. And SAP is really a strong, very strong tool for that.
Thank you. And then also for the next step, so the situation analysis, we have a question. So how would you rate your current relationship with key policymakers in your country? And I will make sure that I move to the next one here. I think you should be able to vote now. Because of course within advocacy we see the policy makers as a key stakeholder.
It would be interesting to know if those responding are from the ESO side or from the scientific side.
Yeah.
But at least where I come from, used to the SSOs having much stronger connections to the key policymakers.
Can we have hands maybe?
Yeah.
Somebody would want to comment.
From the audience. I mean, this is an interactive workshop. So those that, for example, have strong direct access and a regular dialogue with policymakers, are you from an SSO? Are you from a scientific society?
We can maybe say that who is having this strong access? Okay, and we see it, and there should be at least 7 out of us.
Yeah.
Don't be shy.
So please stand up, the 7 of
Yeah,
you.
7.
We
And
Nune,
we all envy you.
Nune, you are a very good example too.
Yes,
Yes.
We want to hear from you.
Yeah.
What's the question?
The question is, are you from the SSO side or
Yeah.
are you a medic?
Okay, I'll shout because I don't think this works. And I'm not clever enough to turn it on. Yes, I am. So I'm from the SSO side.
Yeah.
We do have strong relationships, but it's a continual going around that cycle of advocacy as has been so beautifully outlined.
Is there anybody that is not from the SSO side that has strong connections?
I saw Nune.
Yeah. So Armenia and
Yeah.
Czech
And Czech Republic.
also.
Not from SSO, but still accepted from the Ministry of Health. And our voice is heard, not because me, but I'm representing the whole team of the council, stroke council, which is created to be seen and to be heard by ministry as a advisory body to the ministry for stroke issues. So everything which is decided for the stroke is directed to the council, and the decision of the councils goes back to the ministry. That's why we are very close to the ministry, easily converting the mails, meetings very frequently, so we can speak to them very, very fast and very easy.
So you
Yeah,
created a coalition that is also an advisor to the ministry,
Yes.
basically.
Yes.
I think
Great,
that's
wonderful.
ideal to connect, forces, because it always works better if you are not just one famous professor or maybe famous patient who is advocating for the stuff, but if you are some semi-official, non-governmental, or scientific or patient support organization, of course, that's always the best. And if you are a coalition of such things, always better.
Yes.
Thank you.
Yes. And any other that has a strong direct access would like to share their model? We heard that in the UK is a SSO, is the Stroke Foundation, and in the model of Armenia is a coalition with an advisory board exchanging information and
Okay. So in Ukraine we have a group of professionals, mainly. So they are neurologists, neurosurgeons who have direct connection with the Ministry of Health and National Health Service, and all of us. Some of us represent also World Health Organization and also World Bank. So together with all these communities. We try to advocate stroke to the Ministry of Health and other bodies. So it's a group of people like in Armenia, so the same in Ukraine, but we are mainly healthcare professionals.
All right. But again, the Stroke Foundation would like to say something?
Yeah, I wanted to say that the UK Stroke Association does not work alone at all. So I think if there's one point, we work in coalition with healthcare professionals, with other societies, with other charities actually, so other support organizations to get cardiovascular disease or stroke and get the right answers as part of the solutions. If we were working hand in hand with our healthcare professional community, then we wouldn't all be talking in one voice. So I don't want to give the impression that we're not working in coalition. That is the heart of what we do.
But I think it's what is interesting in it's both in Ukraine and in Armenia is that there is a structure which is usually, I think, both Armenia and Ukraine, it's a structure that is somehow appointed by the Ministry of Health with a ministerial order, if I remember well, and this is the same in Kyrgyzstan and
Czechia too.
And Czechia too. It's a common. It actually is a common practice in Eastern countries that where you have a ministerial order that tells you. But this is also happening in Italy. When we had COVID, we had the same. We had an advisory board that was appointed by the Ministry of Health, and the advisory board is supposed to inform and consult the Ministry of Health for policies and other matters that the ministry consider to share. That's
So small conclusion, try to be in advisory board.
or yeah.
Or if there is not an advisory board, try to suggest this to your ministries.
Or push to have an advisory board.
Or perhaps even, oh, sorry, I interrupted you. Sorry.
Well, no.
Or perhaps even better, stand behind or on the side of your stroke support organization. Ensure that you're speaking with one voice in order also to get into this golden triangle. As medics, you have the scientific facts, and the stroke support organizations, they have knowledge on advocacy and they have lived experiences to support them. I think that is really the way to go for this golden triangle.
Okay.
I agree with that, and just talking for the UK, we do have a split system, and you said you're collaborating with various organisations, but we've got organisations, we've got the stroke physicians, we've got British, Irish, Welsh, Scottish organisations, we've got the speech and language therapists and the physiotherapists, and there are and then you've got the UK Stroke Forum who organises a conference, but not much else. And so there are quite a few voices there, and you're helping to get them together, but we'd be much stronger if we were one, and I think that point is very well made.
Yeah, well, there is another comment over there. Please raise your hand so we can reach you.
Hi, I'm Dr. Vasa from Albania. So
From where?
From
Sorry?
Albania.
Albania, great.
So I'm glad to hear that some countries have this close connection between the advisory body and the government, and we would like to do that, but maybe with some support from the head organization, because the interest is not always so high from governments to accept this kind of collaborations. So it would be a good example to reach there, but with a bit of support, maybe.
Oh, they will provide.
Yes, that we can provide. What we can provide is, of course, examples. We can provide letters where we recommend that there should be an advisory board. There should be an interest at political level into stroke care, and I mean in the cerebrovascular diseases. And we can mention, of course, the SDGs 3 and this year in particular. I think it's the right timing because of the UNGA on September. So that's would be UNGA. Sorry, is the UN General Assembly. Yes, UNGA is the UN General Assembly that is happening in September at the UN, where the NCD will be discussed. And so Albania, did you push the button for a week that you struggle to get attention or access? Were you one of those? Week, all right. What about the moderate? Any comment from those
Yeah,
that...
there is one hand.
There is one hand, I could see it.
Hello, I'm Matilda Florentin from Greece. I voted for week. I think our policymakers, we have communicated to them the problem. They try to establish more stroke units and stroke centers all over Greece. But I think the main problem is that they don't realize what exactly the infrastructure and the personnel should be. They ask for fewer physicians and the other healthcare staff to establish these units. So they can't work 24/7 and they can't provide the best to the patients.
Right.
I think if I can comment, that's why we have this stroke action plan targets, KPIs, where it's defined and should be in future more defined what should be done. There is this essentials package that should be provided. And I think your society definitely must draw from this. And we are, and you will see it, we are trying to push those same targets into the European Commission's targets and plans, so then it will be applicable for individual states in the future. But you can tell them now, definitely, what should be done.
Yeah, and you always well, now there are two papers that are, one is submitted, the other one is in due course. And you can use the papers about, for example, the 2023 data to show what the rest of Europe is doing. So because we understand very well, sometimes it's not easy even to go vocal and to be an activist in your own country could be a problem. So you can show what's happening in the rest of Europe and say, this is what's happening, this is where do we place ourselves, and where are we, where is the position of that given country compared to the others. And this somehow can elicit the attention and because a positive competitive attitude towards implementing stroke care, the different components.
And you don't even have to wait for these publications. You can go to the SABI website where you can find all the data, you can find the maps that we've been showing, you can find stroke in numbers covering the individual countries. I'm aware that some countries don't feel that it is something on a website has the same value as a publication, which is one of the major reasons why this will also be published peer-reviewed. But you can go there and you can find everything.
And now we would like to ask you, who are the key stakeholders with the power to influence stroke care? Sorry.
Yeah.
Yeah.
So this is the
What
question.
is your opinion?
If you're out of the Mentimeter, you can also use mentimeter.com and use the code in case.
Can you put the QR code on again, just quickly?
Yeah, later. Not now.
Fine.
Not if I show them.
Right. So MOH clearly.
Okay. All good Europe ministries are powerful.
Yeah, it should be. I mean, that's what they're there for.
Well, obviously, the Ministry of Health. But this also gives me the opportunity to tell you that on the website of the action plan, you will find a tool that will help you to develop your own stakeholder analysis. There is both a guide and an Excel file that you can use to exercise. It's available on the website. It's among the tools that are provided, together with the structure of how to write a national stroke plan. If you want, if those that didn't have the opportunity, if you want to capture it again.
And then also take a look at the essentials of stroke care, which lists the most important interventions based on international high quality guidelines, which we think is an excellent instrument too.
Yeah, and then maybe to close off with the third step, so we don't have a question for this one, but the third step of the process is to define your objectives. And the stroke action plan already has a clear objective, which is the implementation of evidence-based preventive actions and stroke services covering the whole stroke pathway until 2030. So we will not dive into detail, but this is the third step of the process, which if we get back to the overall steps, we now have discussed setting your priorities, understanding the situation and your stakeholders, and defining objectives. And we will now move into the second part, which is understanding your stakeholders and building a story that actually resonates with your stakeholders. We have a short question again before we dive into that, which is what is the most compelling story or statistic you would use to move policymakers?
And maybe just try to use single words, like procedures like thrombolysis, thrombectomy, patient, whatever. So we have the map nice with single words.
Yeah, I think this is a bit different format of showing it, but.
And you can do multiple.
Yeah, but then I need to change the screen. But indeed, you can fill in multiple words. That's correct.
Stroke is treatable. I like it. Cost-effective treatments. Cost of disability and stroke is treatable. Yeah.
Money and mortality.
Money and mortality, like the M&M. A new M&M version. Money and mortality. I like that. Integrated care. Yeah, and stroke is the second cause of death, the first cause of disability in adults, and a major cause of dementia. Stroke is preventable and treatable. Like that very much as well. Money alone.
Okay, and for building your story, I'll take over on this side. So my name is Angelique Balguiet. I also work for Philips, responsible for the neurovascular portfolio, so very much on the content, on stroke, what we, from a technology point of view, but also for sure what the status of stroke care is in the country, in the world, sorry, I should say in the world. I'm going to show you an example of building the story. I think it is important to pick what you want to communicate about and make it simple, because I think if there's one thing that we have learned from examples of advocacy, don't overcomplicate your message, because I think that only dilutes the impact that you can make. So what I'll share, I saw a few times thrombectomy being mentioned here, cost was measured, disability. I think the logical and actually emotion and the cost to society are really important components. So I'll show you an example of a story around how we can talk about thrombectomy, because it has been, as you know, also quite a revolution in the treatment for stroke patients. And I start with this very old picture of a man, almost 100 years ago, Alexander Fleming. Alexander Fleming was really revolutionary of his time because he invented penicillin. At the time, this was the way to cure pneumonia. And this is something that I'll come back later, the same revolution we're seeing in stroke care, really. Stroke care today, another thing that you want to show, and we had a big event, a ministerial event this week in Geneva at the World Health Assembly, where we spoke about stroke being overlooked and underfunded. Underfunded sort of reflects, in this previous slide, that I wasn't supposed to go here yet. And this is a global picture, but less than 5% out of all stroke patients get treatment. If this would be the case for cancer, it would cause an outcry. If this would be the case for STEMI, it would cause an outcry. This is the case for stroke. So how do we talk about this? How can we make it clear what the impact is of a certain treatment, of an intervention in health, in the health domain? So for that, we use here the term, and it's on purpose not made very scientifically written down, but you all know the number needed to treat, right? Number needed to treat basically indicates how many patients should you treat or intervene or scan to have an impact on one patient. And that means that the lower that number is, the better it is for your patients. So we're starting, as an example, with cancer, lung cancer screening. Obviously, you need to scan a lot of patients to find one patient that has lung cancer. Number needed to treat, 219. So let's take it more closer to home when it comes to thrombectomy. Another treatment that is being done in the cath lab is STEMI treatment, right? Intervention for acute coronary syndrome. The number needed to treat to avoid death, myocardial infarction, or stroke is 39. Now let's go back to Alexander Fleming. Antibiotics for pneumonia to reduce illness. Number needed to treat is 6. Well, guess what? The number needed to treat of all the randomized controlled trials showing thrombectomy in the meta-analysis is 4 to reduce disability. And reducing disability is really the thing that we are trying to achieve because, one, it's less impact for the patient and their families, and of course, it's a major burden on society. So this is something that we can put stroke in the context of the bigger health situation that policymakers, ministers will understand because they also have to answer to cancer care and they have to answer to cardiac care. So this is one to show this to. This is another one. Today, getting stroke care very much depends on your postal code and getting a good outcome of stroke care even more. So it's really something that it shows the inequity that is currently there for stroke care. So we saw some comments just now about money and costs, right? So are costs preventing implementation of thrombectomy services? Well, there are many health economic studies that have been done that proved the cost effectiveness of the treatment, not only in high-income countries, also in middle-income countries. So that is not an argument. We really have very strong case, strong evidence to vouch for this. And if we look at the total impact of implementing better thrombectomy services in a country, I'm showing here an example from the Netherlands where different cost components were shown here over time. And what you'll see here, and I'll explain it a little bit, but the dark blue line that is dropping down is the actual cost, the cumulative cost that has become, has reduced. The delta of cost has reduced over time due to the implementation of better stroke care. And I think this is really something that we do not only see in the Netherlands, but in many more countries where, especially the countries that have implemented stroke care. So these are the numbers you want to show. This is the type of data you want to bring across. It actually can save a society money. The other thing I also want to mention, and I know we had quite some discussion about this in our preparing session, the power of the media. The media also can be an ally. I'm showing here an example. The Guardian in the UK are very active in communicating about healthcare and about health problems. We were talking about the postal code lottery. Well, this lady that you're seeing here lives 30 kilometers away from London and got to a hospital where they only provide thrombectomy services between 9 a.m. and 4 p.m. on weekdays. And she came in the evening. So it was tragic, super tragic, and it really makes an impact to see these type of stories. The Guardian also published about the fact that if thrombectomy would be available universally in the UK, this would save the country £73 million each year and would save 1,600 stroke survivors to be independent. This is the type of information that would be helpful per year to convey to policymakers, to governments. simplifying the story, telling it also in language that is very clear and compelling for them. So we're going to go to Menti. And maybe, sorry, before we do that, I'll also ask maybe Francesca or panel, do you want to comment on any of the
Yeah, yes.
parts?
Actually, we had a very interesting discussion this morning about the two pictures from The Guardian, especially the first one that was shown to you. Because on one hand, I personally believe that positive information, or it's better than a negative information. So you never know what is really behind the story. So what we know is that there are limited services. That's we are very well aware. But on the other hand, so it's important that the public is informed on the limited stories. But on the other hand, it's also we don't want to promote any type of negligence that to accuse of negligences colleagues that are not liable for that, of course. Sometimes is the organization. So I made the example of Italy, where sometimes there are activities that are not available, but this is not because of the physician who is there, it's because it's the organization of the service that is not updated or is not completed, is not implemented fully. So we are very well aware of that. So the other, a positive option is to bring up positive examples, like this person has been treated and the good results, and what it will be like treating more cases, so improving the quality of life of patients and families, and this is cost effective, and so tell the story from the positive angle. This is because, of course, when you look at things from a negative angle, it's more, you never know what is behind it, at least in what we think. That's what I think. Mm-hmm. So it's just to encourage you to use the media, how you think is best and how you think is more efficacious in your country.
I would like also to be a little bit concerned about especially physicians going out with stories, because as a physician you have a duty to be a truly expert in that case, and that would mean that you should know the patient file, etc. At least in Denmark, you're not allowed to go and there's the GDPR things. This is something which works much better with the stroke support organizations. But I would like very shortly, to tell you a story of a collaboration between physicians and stroke support organization in Denmark that has actually led to action. This was not about. This was about highly specialized rehabilitation, which in some municipalities was just a sign above the door, and this issue was raised by the stroke support organizations and went to media that way. And then we were included in the conversation as experts based on the recommendation of including people with insights into rehabilitation. And from there we actually ended up getting what we have wanted for so long, and that is a quality registry also covering the rehabilitation in the communities. Mm. So you need to collaborate. You need to do what you're good at. You shouldn't go where you're not confident. Mm.
And I will add just one more for the stories. Of course, I always try. I did for our society many press conferences, and journalists always want a nice story, like a cherry on the top. So you either cooperate with stroke support, or you ask your own patients unorganized. And of course, you need to select a nice-looking patient. And I'm also like Francesca. It's best to go with positive examples and showing some miracle treatment, that showing that stroke medicine is for God's, it's like God's work, that you make patients who were really disabled to be healthy. And then people would like to follow this example in regions where it's, for example, not available. So I'm definitely recommending picking up communicative patients. You know, not all patients are good with media. And dedicated patients, and I have experience knowing a couple of such patients who then started, after we asked them once, they started the advocacy work and ended up working in some stroke support organization. So you can promote your patients to work on this. Yeah. So I recommend it, because journalists want always new story. Like, you do every stroke day every year, of course. You need new story every year.
I think the UK wanted to make a comment. Please. I saw. Sorry, I called you UK about that, but the stroke organization. Apologies.
You guys made the point brilliantly, actually. So I was just going to echo what you said, because the two pictures that you showed up of the article.
Where yours?
Well, the first one was not. So the patient story actually was not. But we created an environment where then patient stories started coming out. So the negative story was not ours. The second one was based on work that we did with the clinical community, created a document, a manifesto, which then created that second story.
And it was picked up.
You guys already said exactly.
Yeah, the second story is the story we like.
Yes,
the first story,
yes.
I think it's there are many there are many issues with the first picture, I think.
Yeah, but
So-
what it does, I absolutely, I recognize what you're saying. What it did, I think also, maybe you noticed that, it opened the parliament to talk about thrombectomy and about the fact that this is not available.
Yeah, we know from American presidency that even bad news and drastic news promote discussion, and you know.
Yeah, you might have a president that says this is fake.
Yeah.
Whatever.
Okay. Thanks, a great discussion and great insights, and I hope this helps also to build the story. So we've looked at building the narrative, right? And in there were the problem, the policy, and the politicians. Actually, we're getting to that building alliances now. So building alliances was mentioned earlier. It's really important to find your allies, and maybe it's not even only within the field of stroke, but indeed in cardiovascular disease, whoever could be allies to reach your goal, reach out to them. So just one of the things that also I wanted to share with what we have been doing together with the World Stroke Organization, but also ESO is part of this, the Stroke Association, American Stroke Association, March of Dimes of Canada, and SBIN in the US, is the founding of the Global Stroke Action Coalition, and you'll see that there's also industry partners in there. And I'll explain also why, what role industry plays in there. Besides the connection with ministries of health, big corporations have that as well. So we have direct connections with governments. That doesn't mean it's always easy to get stroke on the agenda of a big corporation, because we work for Philips. We do many more things than stroke, cardiology, mother and child care, cancer, a lot of things. But what we are trying to do is, with some large corporations, also try to get stroke more on the agenda under the umbrella of the Stroke Action Coalition, so that not only the societies are making a plea for better focus on stroke, but also the industry side is doing so. And we have different ways to bring that message across, but it is something that can be powerful. Just to show some of the alliances that are happening besides the Global Stroke Action Coalition, you're familiar with the EACH alliance. ESO is part of that, but also MedTech Europe, which is a trade association where all MedTech companies in Europe are part of, so amongst which some of the companies here. And from these, EACH and MedTech Europe, but also SAFE and the Ian Brain Health Mission, sometimes policy papers are being written, policy recommendations that actually are being sent to European Parliament members, so that they can read up on what are the opportunities. And this is really where, if we create one voice, that can be impactful. So in EACH, there is clear mention of what should be done in stroke. The MedTech Europe report also now very clearly has a statement about stroke being an important important opportunity to improve healthcare in Europe. And some of the policy briefs that have been developed either are driven by the stroke coalitions, but sometimes they're driven by others, and that's what you see on the right-hand side. There are ways to influence politicians and governments and policymakers around by making sure the right message is in those policy briefs. So we have another Menti question. Which organizations, patient groups, or healthcare professionals could you partner with to amplify your voice? Which stakeholder groups are your allies? And this is again just where if you drop it in, it should pop up as a separate line item, I think. Yeah, here we go. None really. I'm not reading this. Oh, this is difficult here. Shogun. The Angels, yes, indeed. Stroke Association UK, France, ABC, patient groups, healthcare professionals, Alice. Yeah. Yeah, so great. And I think this is really important as well. Look for your allies and look what you can do together, join forces, find common goals, find common objectives. Because this just helps to have a louder voice.
Alice, it's my Italian, yes.
Yes.
Yeah. Absolutely, ESO. Yeah.
Okay. If I may comment on this,
Please, yes.
I'd like to say that I think it's very clear and very nicely shown how there are multiple levels of collaboration and potential allies. And multiple level means that you have national possibilities, of course, with international, and also you can reach out to international association, and this can be so you can play actually between what is national and international to strengthen your voice and to be vocal about what you would like to, where you would like to focus on. Because again, I think it's very important that when you keep working on pragmatic, be very pragmatic when you choose when you triage your priorities, because the priorities must be priorities for the healthcare, but also it must be something within your reach. So something that you can do, even just partnering with, for example, with SAFE or with Angels for the Fast Heroes campaign. If you can do that, and it's the only thing you can do, please do it, because it's a result. It's being pragmatic, and from that you can build on. So this is a process. It's a marathon. I think even though time is brain, we know, but it's. I mean, my view would be to consider it a marathon, the 42 kilometers marathon, not the 100 meters, because if you lose all your energy, if you spend all your energy at the very beginning, you get exhausted too early, and this is going to be really long. At least this is my point of view.
And you won't make the finish line, right?
Yes.
Yeah. Yeah,
that's
so
why Stroke Action Plan is planned for such a long period.
Exactly.
You may notice that our targets should be done in 5 years. So that's unfortunately this type of policy changes it doesn't happen immediately. You always need to be prepared that every change takes 2-3 years. I'm in this process like for the last 15 years, so I've seen some changes, but they always come once in 2 years or something like this.
Okay, so let's speak a little bit about outreach tactics and also understanding what would be the steps to do so. And we spoke already about the multifaceted elements that play a role in really reaching a better system of care. It's about making stroke a priority as part of your NCD health agenda. It's about developing national stroke action plans, which you've been doing, right? Committing to funding to act now. Implementing robust stroke monitoring systems, including stroke survivors and caregivers in policy development, but also capturing the data and showing the results. And that's a really important one. And I think one other really foundational one is indeed support of governments and policymakers. And just as we spoke about the Sustainable Development Goals, I think this is really again, the window of opportunity that we have this year, it's the year of the non-communicable diseases. Next year, there will be monitoring for what is the implementation of the focus of non-communicable diseases on the UN agenda. So if we state the Sustainable Development Goals number 3.4 specifically around Sustainable Development Goals of the United Nations, it actually says to reduce the burden of non-communicable diseases. And tell you, and you know this is not going to be achieved if you do not address stroke care. Stroke is really the key to actually reach this goal. And so with that message, we have gone out to that top level, to the Ministers of Health gathering every year at the World Health Assembly, which is coincidentally this week. So I literally came from Geneva yesterday, where we wanted to focus on stroke. And actually, believe it or not, last year, together with the World Stroke Organization, was the very first time that we actually had a stroke panel discussion dedicated to stroke care on the World Health Assembly. It hadn't happened before. It was just not there. And so the first time we launched a policy brief. We had ministers of health from different countries, Latin America, Indonesia, and this year, actually, it wasn't only World Stroke Organization and Philips, but this year we had the whole coalition. So it was several societies, several industries together there to voice the fact that we want to focus on this. We launched a policy brief under the Global Stroke Action Coalition, launched a campaign, which you might have seen already, Every Minute Counts, under the umbrella of the Global Stroke Action Coalition. And we had the panel discussion with World Health Organization at the table, with the NCD Alliance at the table, with the European Investment Bank also in the room, ministers of health. And I think this is really what can be spreading the word and creating also more momentum for this topic. And I think a really important component that we're doing also top-down by working with this coalition. So this is actually the last question, and I think we can have some discussion after this, and then to wrap it up. But which channels, and this could be on various different levels, media, events, one-on-one meetings, government meetings, social media, will be influential for you are most effective in influencing decision makers in your country? What do you think? Social media, TV, one-on-one meetings, LinkedIn, social media, lots of social media, events, patient stories and advocacy, one-on-one, lobby meetings,
X,
public campaigns, events, social media, TV, news,
most effective.
policy reports, patient stories. Yeah, absolutely. And I think this is also where alliances can help. And I think what we've seen with the Global Stroke Action Coalition, we have also patient support group being part of that. We've got industry. So if we think about having nice patient stories, you were talking about a good-looking patient. It does help to have a good picture, to have an appealing visual when you create a campaign.
Yeah.
It does help
dog
to have
or puppy.
Yeah, sorry.
Sorry, just adding up,
Yeah.
I know it's
it's
a little bit like a joke, but
yeah.
definitely ask our patient to come with his nice Labrador. It makes the story more compelling for more people.
Agree,
You need to be aiming low.
Yeah. And one of the things that we have also been doing now in what could be a channel is a roundtable discussions where we bring together clinicians or the medical society, the politician, a patient, and actually and policy advisors to discuss about what can be effective. And we would love to ask you, have you considered organizing a roundtable with stakeholders in your country?
I would love to ask you, have you considered supporting this activity in their countries?
I absolutely would be open to do that. We've got a little bit of experience with this, and I think actually, may I ask the Dutch delegation to share a few words about your planning to do a roundtable, and we are indeed also working with the Dutch team.
Sure, happy to do so. I think one of the challenges in the Netherlands is that at this point in time we don't have the buy-in from the Dutch Ministry of Health yet. So we believe that a roundtable with carefully selected experts from both the medical field, the scientific field, and patient experts may provide a strong policy brief which will hopefully attract the attention from the minister. And we are indeed discussing this with Angelique and Ruth and colleagues to make this happen. And we're looking forward, or our planning is to have this roundtable in about 6 weeks' time from now, and have the policy brief ready and handed over to hopefully the minister on World Stroke Day.
This is very important. Thank you for sharing. But I have a question for you before you get back that. Thank you. Is at the round table, is there any, real, because it's, you mentioned mainly me, you, she, and her at the round table. So, but do you have policy maker at the round table? Because we are not policy makers, we are the experts. Will you have because I think this is what is really the game changer, is when we do the policy brief, we have a lot of those, but will you have a politician sitting at the round table?
We are aiming for having them sitting not at
with
the
you.
table, but listening, because otherwise they will have to vote on their own policy brief, right? So they sit in and comment and listen. And then the policy brief will be discussed at the ministry, and it's going to be very complicated if someone from the ministry is sitting around the table.
So, so what you're saying, I think, is very important. So you will not be only the experts, but the policymakers will be there from the beginning to the end. Yep. Not just for the opening. I'm just saying this because this opened happened, for example, in my country, I'm Italian, where you invite maybe the director of the health department of your region. They come because they're very nice. They stay 20 minutes. They say how important is what you're doing, and usually they quickly have something else, which I understand that because they do really have a lot of things to look after. But on the other end, I think that once you do a round table, it should be done exactly as you described. You should have people listening, commenting, and then agreeing on key messages that should be delivered up high. Yeah. Thank you.
One more note, which hopefully will make you happy. We will be making use of SEPI as one of the base documents for the roundtable. So.
Thank you. Let us know if you need anything from us, from the stroke service tracker, or from other data that we can provide you with.
And I'd like to also invite, there are 4 people that said yes, and we can share experiences. We'd love to hear from you.
Yeah, so basically, so I'm from a company that is working actually on the pre-hospital like stroke diagnosis and EMS, but I'm also a delegate of a business school in France, and it's a very good business school. So we're trying to do this roundtable, and my strategy is actually to do it through the platform, the school, because we have a lot of alumni that is now in very high positions in France, French government. So we invite them to the school and to do the roundtable there. And also another strategy we're trying to do is, because now, since we're actually an AI company, so we also try to go through the angle of AI, which is, in France, they're trying to make a lot of effort. So we're trying to contact not just the health ministry, but also in French government, they have a digital ministry that is, oriented to AI. So we try to engage them as well into the conversation.
Well, this is fantastic. Please leave your email here. I want to know more about this. But this is also another very good examples when you have group, when you have the academia, where usually is social sciences or finance, healthcare finance that does this type of studies, which are very interesting for the political, not only for the Ministry of Health, but also for the Ministry of Finance or technology. This is really interesting. Any other success story? At least other two.
Anybody else that has a success story with organizing a roundtable, or at least a gathering with the different stakeholders that would like to share?
Maybe I can just a small share, because I was one of those who had organized a roundtable, and we did once use, for example, you can use every crazy opportunity to start this activity. Definitely there are these periodical holidays like Stroke Day twice a year, which is fortunate, so you can celebrate both of them, not just one of them. That's what we do. And we happened to have found that, for example, American Embassy in Prague is interested in connecting some business activities between countries, and we applied with program on stroke and developing stroke care. So you always look for any opportunity that you can push your agenda. So that's what I would say. So we happened to have workshop. We were supported by the American Embassy, and it brought our ministries to this, and the full round circle then goes on.
Find your allies, right?
Yeah,
Find your allies.
Angels, for example, is a very powerful ally, and yesterday at 10 o'clock at the Angels booth, Kyrgyzstan, the representatives from Kyrgyzstan signed an agreement that was there, and that it was previously signed by the Ministry of Health of Kyrgyzstan himself, and now they are about finally, we hope so, to sign the declaration. So this is also very, very nice. But these are all examples that we bring up just to also see if this rings a bell and can be done. But the roundtable, Angelique, thank you, because it's if it's something that generous offers from your side.
Yeah, we would be very interested to continue to participate. And we also see that it helps sort of best practices that are contagious when we look at different countries. Ministers of Health want to show successes as well. So this is something that could be helpful. We are at the end of the session. For those that have not registered and would like to get access to these slides and also some more tools and sort of the methodology behind what we went through, because of this was nice presentation mode. There are also a bit more templates and templates to be used for this, to structurally take you through the steps, and of course in combination with the SAPI tools that are there. Please do register if you're not there yet, and you're going to receive this information. If you want to reach out directly to myself or to Ruth, feel free to drop us an email, and we would love to stay in contact. Maybe just one thing, there's in Barcelona in October this year, there will be, of course, the World Stroke Congress. We hope also maybe after evaluating to do something like this again, so it would be great to also get your feedback on if this was useful for you. So thanks a lot.
And please remember that the SAPI SOFA, this means me and Hanne and Alish and Arlene, are always open to any help, any request. Please come to us. Arlene is super magic about advocacy, and we are here. And Albania is here.